Welcome everyone to the next webinar in the CMHDARN Research Webinar series. This is webinar 5, What is an Evidence Base? I want to start today by acknowledging the traditional custodians of the land on which I am today, which is the Gadigal people of the Eora Nation, and pay my respects to elders past, present and emerging. The CMHDARN Research Webinar series is an ongoing project to support people to build their research skills in the non-government mental health and alcohol and other drug sectors. All the webinars have been, and today is no exception, presented by people who are experts in the fields of research and our sectors. We've had webinars on why research should be conducted, the ethical considerations of research, and how to develop your research question, and more. Today, we're going to be talking about this thing called an evidence base. What is it? Why do we need it? How do we use it? And how do we get access if we're not at a university? First off, you'll hear from Steph Kershaw, who has been very involved with CMHDARN over the past few years. Dr. Steph Kershaw is a postdoctoral research fellow at the Matilda Centre for Research in Mental Health and Substance Use. Steph leads an innovative program of research and translation on the prevention and treatment of illicit substance misuse. Her research aims to improve the health outcomes for individuals, families, and communities, especially among vulnerable and disadvantaged groups. Steph completed her PhD in 2015, after which she undertook several appointments at the World Health Organization in Geneva, Switzerland, focusing on the impact of illicit drugs on public health and the translation of evidence-based research into international policy outcomes. Steph is currently project lead for Cracks in the Ice, a national online portal funded by the Australian Government Department of Health to develop and disseminate evidence-based resources about methamphetamine use for the Australian community. Steph also leads Australia's first project to develop and adapt culturally appropriate resources for Aboriginal and Torres Strait Islander peoples to reduce the impact of methamphetamine use among communities. After we hear from Steph, Steph will be joined by Belinda Volkov, and a bit about Belinda. Belinda is the clinical coordinator at the Sydney Drug Education and Counselling Service, which is also known as SDEC. Belinda has over 20 years experience working with young people with substance abuse and mental health issues, as well as counselling parents of young people with these issues. She has a background in social sciences with a postgraduate degree in addiction studies and a Master of Social Work. Belinda has also been involved with CMHDARN over a number of years, most recently as a grant recipient and a mentee in the Community Research Mentoring Program. Belinda and Steph will discuss some of the benefits of partnership, access, when it comes to evidence, and the translation of evidence into practice, while also discussing how you can add to the evidence base. After their conversation, there will be chance for questions. To ask a question, simply click on the Q&A button at the bottom or the top of your screen. You can do this anytime throughout the presentation. However, we will leave answering questions until the end. For now, please join me in welcoming Steph Kershaw. Thanks.
Hello, everyone. So thank you, Jo and CMHDARN, and welcome everyone. I'd like to echo the acknowledgement of country. I'm coming to you today from the land of the Gadigal people, and I pay my respects to their elders past, present and emerging. And I'd also like to pay my respects to the elders of the lands on whichever you are coming from today. So I'm going to be talking about what is an evidence base and how to look for evidence. But I do want to start by saying this is a very brief overview. There are lots of extra resources and information available, and I am more than happy to share my slides with anyone who would like a copy. So what exactly is an evidence base? Well, it means that something, whether it's policy, guidelines, or an intervention, is based on the best available evidence to date. Now, this evidence is generated through scientific research, which explores new ideas or questions with the aim to gain knowledge or validate existing knowledge. And true scientific research is conducted through rigorous methods to make sure that it produces the best information and evidence. This is important for us to look at, as an evidence base, or research evidence as it's shown in this picture, is one really important part of evidence-based practice. So evidence-based practice, or knowledge translation as it's also sometimes called, is an approach to care that aims to integrate the best available evidence along with clinical knowledge and expertise, while also considering client or patient unique needs and personal preferences. It ensures that clients receive care that is based on the current evidence and that outdated, ineffective, or even unnecessary treatments aren't being used. Now, there are a number of general steps involved in the process of employing evidence-based practice, and these are roughly listed here. But today I'm only going to be focusing on step 2 and 3, which is acquiring the evidence and then briefly touching on how to appraise it. Well, where can you find evidence? Well, you can access and search the latest scientific research literature through a number of databases. And I've listed a few examples here of useful public databases, including PubMed, Biomedical Central, ResearchGate, and Google Scholar. And these databases are easily accessible and often have links to the full text of articles. I've also put here the Cochrane Library, which is a great resource, particularly if you're interested in finding up-to-date systematic reviews and other synthesized research evidence to inform health decision-making. And we'll talk a little bit more about systematic reviews later. Now, you may also be familiar with other databases through your work or if you're studying. So assuming that you already have a research question in mind, then the first step to searching the literature is to identify the keywords and or phrases of your topic, as these will be your search terms. So you'll need to filter out words that are not going to be useful for your search, as the search engines of databases will look for exactly what you type into them. So you don't want to include words like the, and, or of. So what I like to do is I like to write out my research question and then highlight the main words in it, as you can see here with this example. So the highlighted words, affect, heat, pollution, mental health, Australia, will be the keywords that I use in my search. It's also good to think about what alternative words there might be to your main words. And sometimes it's useful to do this in a table. So for example, the alternative words for effect can be impact or outcome. And so you might want to run a few different searches with different combinations of words to make sure that you're picking up all the relevant research literature articles. Now, there are also lots of tips available to help with searching, and a number of universities handily have online library guides about how to search through databases and find what you're looking for. And some of those tips in those guides include things like if you want to search for a phrase such as mental health, then it's a good idea to put double quotation marks around the words, as that tells the search engine of the database to look for these specific words in that order. It's also a handy thing to use truncation. So truncation lets you cut back to the root word. So in this example, pollute. So truncated it from pollution. And the search will then find all the related words to that root word, like pollution, but also polluted, etc. Now, it's important to realise that each database actually has a slightly different search engine. So if you haven't run a search in a database before, I'd encourage you to look for the user or help guides, as this will have all the handy tips and tricks for that database. So now, excitingly, we can run our search. And as you can see, using the terms mental health and pollute, we got 784 results, which can make you feel quite overwhelmed. And there's simply not enough time to look at every paper. But handily, no matter what database you use, there are always a number of filter options available. For example, you can refine your search to just full text articles, but you can also refine your search depending on your research question. So if you're looking for a certain type of data, such as you might only want to look at randomized controlled trials. However, the first way I would recommend that you sort or sift through your results is to look for literature articles from the last 5 years, ideally. You can stretch it out to 10 years if you're really not finding anything. And the reason we operate in this 5 to 10 year timeframe is that research is an ever growing and changing field. There's always new discoveries and new ideas that are being tested and reported on. So it's really important that you look for the latest research. And I like to think of this as, think of how much we've learnt about the brain just in the last 10 years, and we've still got so many secrets to uncover. It's also important to look at what kinds of literature articles have come up in your search, as the different types of research studies have different weight in terms of scientific evidence, ranging from strong to weak. And this brings us to what is called the hierarchy of scientific evidence. So this is just a general guide, and there are several slightly different models, but generally they're all quite similar. So I'm going to talk a little bit more about each of the studies listed here. So starting with the strongest scientific evidence, which is considered to come from meta-analyses and systematic reviews. So systematic reviews is a process of carefully combing through the literature for information on a given topic and then condense the results of numerous trials into a single paper that discusses everything we know about that topic. Meta-analyses go one step further, and they actually take the data sets from all the multiple papers and run a statistical analysis across all of them. So both of these designs, meta-analyses and systematic reviews, produce very powerful results because they avoid the trap of relying on just one study. But they do have their limitations. So it's always important to look at their inclusion and exclusion criteria to understand exactly what is and hasn't been taken into account in their analysis. So this is then followed in the hierarchy of evidence by randomized controlled trials, or RCTs. And these are the gold standard of scientific research. Now, an RCT is where a specific population is selected and then half are randomly assigned into a treatment or intervention group and the other half into a control group. Strong RCTs also employ what's called a double-blind method, where the researcher nor the study participant know which group they have been assigned to. RCTs are considered to provide the most reliable evidence on the effectiveness of interventions or whatever it is that's being assessed, as they are conducted in a way that minimises the risk of confounding factors. Next in the hierarchy of evidence, we have cohort studies, and this is where you take a group of people that you're interested in and you follow them up over a period of time along with a control group. So for example, we run a number of cohort studies at the Matilda Centre looking at the impact of a specific evidence-based drug education on school-aged children over time and whether that education has any impact on their drinking or drug use patterns later in life. We then compare that cohort that's had that special drug education to a control group of school-aged education who've received the standard curriculum. We then also have, towards the middle of the pyramid, entering into the orange area, case-controlled studies. And this is where two groups are compared, one group with the outcome of interest. So for example, it might be alcohol use disorder, and they're compared to a control group, so people without an alcohol use disorder, and researchers look at the frequency of particular or potential causes. We then also have cross-sectional studies, and these are called observational studies because they look at the prevalence of a particular trait in a particular population at a particular time. So the easiest way to explain that is, for example, if we said how many people have a substance use disorder or dependence in New South Wales in February 2021, and that would be a cross-sectional study. So these studies don't really look at cause and effect, and they can be influenced by other variables that aren't being looked into. Now, towards the bottom of the pyramid, we have animal trials, our in vitro studies, and these are sort of test tube in the laboratory studies. And they aim to figure out if something is safe or effective, like a drug or a vaccine, before going to human clinical trials, or to understand more about how certain chemicals or biological substances work or interact together. They're often a great starting point for research, but as human physiology is quite different to what happens in a laboratory or in an animal, they are quite limited. And then finally, the weakest evidence is considered to be case reports, as it's often only a report on one or two individuals. And along with that, we also have opinion papers and letters to the editor, which are very much personal accounts or authors arguing for a particular position, explaining why more research might need to be done in an area or problems with a particular research article that's been published. So when you are looking at your results from your search, it's important to think about this hierarchy and where the papers you are looking at sit. I do want to say that the hierarchy is quite flexible. So sometimes a really well-designed randomized controls trial or a cohort study might actually provide a lot of useful information for services with complex client populations, even though it's not the strongest form of scientific evidence. So coming back to your search results, what you want to do is you want to look at how many relevant studies have been undertaken in your area of interest and whether they found similar or different results. Now, it's really important to look at the entire body of relevant research, not just those 1 or 2 articles with interesting titles. I know it's very attractive to do, but you've got to kind of have a wide breadth, because as the odds of a single study being flawed or having a lot of limitations is quite high. But if you're finding lots of studies with similar results, then that's telling you that you can have more trust in the conclusions of that research. And that's where those systematic reviews and meta-analyses can be really helpful. I do want to say that it's actually okay if after looking at the evidence, you can't come to a conclusion. And all you want to say is there needs to be more research. An example of this is a recent systematic review that looked at the studies on mental health smartphone applications. And it found that while mental health smartphone applications have potential in improving and monitoring management of mental health symptoms and disorders, there's currently a lack of clinically validated evidence of their efficacy. So more research is needed, and that's okay, because doing more research means that we can minimize the flaws and develop a stronger evidence base. Now, when you're reading through the article, it's important to critically appraise it. Think about what the article is about and what are its strengths and limitations. Some of the questions you might want to ask yourself when you read it is, what is the aim of this article? Is it actually relevant to what I'm looking into? Is this a study similar in terms of design that I'm interested in? Does that study design make sense? Are they making good comparisons? Does it need a control group? Are there the right methods being used? You know, is the number of people or the sample size of that study large enough or meaningful enough? Or are they making grand conclusions of just looking at 10 people when they really should be looking at least 100? You also really want to think about, what are the limitations of this study? What does this study not cover? Sometimes it can be those cultural and linguistic diverse needs, or they may only look at a certain population, so it's not representative of an entire sample. So this is actually a super short overview of how to appraise literature, and it's something that actually takes time and practice to develop. But luckily online, there are plenty of checklists and online training available that can help you develop those skills to critically appraise articles if this is something that you're interested in. Now, even I, who work at a university, have difficulty accessing full article text sometimes. Luckily, some universities and workplaces often have access to a lot of journals, and so you can easily access full text. And there are even some journals that are what we call open access, for example, +1, and that's where all scientific articles in that journal are immediately and freely available to anyone, anywhere. And there has been a push for more journals to do that, but it hasn't progressed as far as we hope. But hopefully over time, we'll see more open access journals. My biggest tip for you though, is if you are having trouble accessing full text, email the corresponding author. Every publication has to have a corresponding author attached to it, and you will be able to find their email address somewhere in the abstract or in the author details. So here are 2 examples. The one on the left, there's a little mail symbol next to my name, Steph Kershaw, in case you've already forgotten it. So if you click on that mail symbol, it gives you my details, including my email. Also on the image on the right, you'll see that there's an email address in the author affiliations. And do not be shy about emailing authors. I would love it if people emailed me for my articles. It would make me really happy to know that there was someone super interested in what I had been researching. But even then, sometimes you won't be able to access articles, or you might want to know if what you are reading elsewhere, like reports and booklets, is evidence-based. So what are some quick tips on how you can make sure what you're reading is evidence-based? Well, an easy one is to see if there are references or key sources listed in the text or at the end. or even a link to a reputable site you can go to for more information. You also want to see if there are quotes from experts. So with this one, I'm particularly thinking about media and newspaper articles. It's usually a good sign if they've got a quote from researchers, clinicians, or people with lived experience. You also want to think about the way things are written or reported. Does it seem exaggerated or sensationalist? So as Joe mentioned, I work in the field of methamphetamine. So I often see headlines like ice epidemic, which we know is sensationalist because the prevalence isn't as high as the media likes it to be portrayed. So you really want to see, is it a balanced written article? Does it cover the pros and cons of issues? And if you're looking at websites, is it a government website or an organisation-based website? What information do they provide about themselves and where are they getting their information? Another way you can find out more about the latest research and evidence-based practice is to link in with research centres, peak bodies or universities to help build the evidence base. Now, these are just a few examples here: NADA, Black Dog, Matilda Centre, Turning Point, etc. I'm sorry if I missed out your organisation. I started off thinking that I'd just give a few examples, but then I realised there were so many out there and I couldn't possibly show them all. You can also try searching university websites with the topic areas that you're interested in, as this can help you find academic profiles of people who might be doing research that you're interested in. Other ways to keep up to date with the latest research is to look out for research mentoring programs. So I would highly recommend the CMHDARN mentoring program, where mentees from clinical services are matched up with researchers like myself to help build their research skills and capacity. It also is great for researchers like me to understand more about what is happening in clinical services and what are the areas that we really need to be prioritising to do more research in. And I actually really enjoyed and valued this as my own mentoring. So I highly recommend it. It's also good to keep an eye out for new guidelines in your areas. For example, NHMRC run a site where you can search for relevant clinical guidelines. And you can also stay up to date with events and webinars. So thanks to COVID, there are actually a lot more opportunities that are now accessible online, including virtual conferences. But I'm also a big fan of webinars, as they're often short and you can eat your lunch while you're watching them. And they present the latest research and evidence. So I'd just like to recommend taking a look at the NADA website, which lists a lot of current events, including webinars. There's also the Insight webinar series. And because it's close to my heart, I would like to mention the Cracks in the Ice project, which runs a webinar series around methamphetamine. Now, there are a few resources about evidence-based practice or modules or helpful information about finding and evaluating research evidence. And I've put some links here, and I'm more than happy to share my presentation with anyone who would like a copy. So thank you all for listening, and I hope that you have found and learnt something new and useful. I'm now going to hand over to Belinda to make her presentation about how to put evidence into practice. So thanks, Belinda.
Oops, thank you. I'm getting there. There I am. Thank you so much for that, Steph.
Fine. I just did notice there's a comment in the chat from someone, and yes, absolutely, librarians are your best friends and they will absolutely help you if you need. And also involving people with lived experience is a great way, particularly if you are looking to embed evidence-based practice.
And thank you. I just also want to start by obviously acknowledging the traditional owners as well. I'm also on Gadigal land, part of the Eora Nation, and I welcome, thank you for having me, and respects to anybody in our audience today from Aboriginal and Torres Strait Islander. Thanks, Steph. You know, just even listening to Steph, I wish I'd met Steph about 10 years ago. I'm hoping that what I can do today is actually give you that kind of idea. So all of us that are actually in the front line of the sector, how do we actually, get this rich experience and the stuff that we can do that contributes to such important discourses as Steph has discussed, and kind of feel like we can actually do some of that grassroots work. And so for myself, I just wanted to tell you a little bit about SDEC quickly, if you're not familiar with it, which is Sydney Drug Education and Counselling Centre, very long acronym. And it's been around for about 50 years or so. I think I've been here for about 18 and have watched the service grow. But the reason the service has grown so much actually has a lot to do with being involved with CMHDARN and the mentoring and a lot of the work that they have supported us with in really, I guess, putting us on the map. So our service is a specialised service, free counselling for 12 to 25-year-olds who present with comorbid drug and alcohol and mental health issues. We don't work with drugs separately to mental health. I'm still uncertain why that's an issue, but it does happen. You would all know that. Support and counselling for parents. So we run intensive programs for parents because quite often the young person may not be done yet. Quite often I don't get 15-year-olds kind of saying I'm really done with my drug use and, you know, and I'm over it. So we have to work very intensely with parents. And in fact, our parent work was something we were almost doing. We were kind of almost hiding parents for years because that wasn't the funding that was based. The funding is often based for what is the for want of a better term, the pathologized individuals. What do they need? And then we've got, and as we know as workers, they kind of come in this context. So as an organisation, we already work with these frameworks around comorbidity and harm minimisation. We're big on the family inclusivity, but doing it and not being tokenistic. Yes, we work with families and that's it. So we're really concerned as an organisation, how do we get that family work on the agenda? And these are all the things that brought us to have the relationship that we've really enjoyed with CMHDARN, and because of that, many others such as Steph from Matilda Centre. So, you know, for us, we work in a very multidisciplinary team. You know, I'm the clinical lead for about 10 clinicians, and we used to do a lot of education and training. We now just do training and education for capacity building for workers. And do a lot because in the sector, drug and alcohol, if you didn't know, can sometimes be viewed as the ugly stepsister of mental health. And I don't say that to put us down. I just know what stigma and discrimination does, and as all of you would too. And imagine if we didn't have that. So all of these things have brought us to this point with CMHDARN. We have a consultant of a psychiatrist that we're very protective of because you know how rare they are. The family therapist was one of the people we involved in our preliminary kind of understandings of looking at developing our model of service, which is where a lot of this stuff with CMHDARN was very important for us. And we have 2 locations at Manly and St Leonard's. So I've just put this up, this Be Unique or Die, for the simple fact that what was so interesting was in about 2014, when we almost all lost our funding and it was a rather frightening time for a lot of us. We actually got, so we run off about 4 different tenders now, but at the time we didn't, and we got that capacity building funding around mental health, and some of you may be very familiar with all that. And we did the DDCAT and looked at kind of, you know, if we met criteria, and we were travelling really well. But the Commonwealth government at the time pretty much gave us, and they literally said this, which is why I put it on a slide, be unique or die, which is rather disturbing when you're working in an NGO. But what they were saying to us is, pick up your game, you know, and we know in the NGO sector, we're so busy doing the client work, right? We're so tired. We're so, you know, I say tired, but not jaded. That can change sometimes. But it's really hard, and people are like, I don't have time. And as a clinical lead, I know what it's like to have to get buy-in from your team if you're enthusiastic and half the team isn't, depending on the size of your organisation. But I can tell you since CMHDARN, we went literally from about 2014, I only had about 3 clinicians and I now have 10, and we're across 2 sites. I really do think that this work has had a lot to do with actually putting us in line to be able to grow and develop capacity in our own service, which we all desperately need. So this is why I put this up here, was be unique or die. So then what did we do? Well, at that point, we'd already been working with families and parents, and as I said, running intensive groups for them during that time, and working with young people. But we had this kind of model of service delivery. So what we were looking at was we were separating young people and parents, because if you work at the acute pointy end of comorbidity, all you need is a big whistle. It doesn't matter how many clinical skills you have. You've got people who are hostages in your room, the clients are, and so are the parents, because they're here to fix somebody else. So it was just never something that we wanted to kind of embark on, but we did want to develop the levels of family inclusivity, and we're quite known for that now in our model. In formulating the model and making it more palatable for not just for academics, but to kind of set ourselves in stead to become a centre of excellence, which was what was our goal, we went down this road. So at the time when we applied for the CMHDARN grant, I very remember, you know, I mean, most of us have imposter syndrome, as in, you know, could I possibly be good enough to contribute anything? And that's not because, you know, half the time we don't get to meet people like Steph. I think Stephanie...
I would also like to point out, Belinda, that even Stephs of the world have imposter syndrome too. And academics always wonder if they're suddenly going to be found out that they're not that clever, really. I mean, I can't actually make coffee without spilling it. So please don't ever feel, you know, intimidated.
Yeah, and I love that you said that, Steph. It's really, really important. We do get the old Dunning-Krugers, but they're the ones that don't have all the skills and think they do, but that's a different conversation. Most of us have imposter syndrome. What's so important about that, and Steph's absolutely right, it wasn't until I met people from academia, because I think, you know, I felt intimidated and scared, not because of anything else other than it just felt so separate to services. And this is where CMHDARN has just been incredible for us. So at that time, I was kind of trying to do this lit review. I wrote this lit review anyway. And at the time, what I did in terms of data, because Steph and I and Joe spoke about this, the biggest issue was about how do you actually access data. And I would have been divine to have Steph all those years ago. So she's giving you some amazing tips. For me, I dragged on my second master's longer so I could have database. Commitment or ridiculousness, I'm not sure. But what I did know was that was one of the big barriers, like how do I get the research? And Steph's given some fantastic points to that today, and I would certainly download her PowerPoint and be reviewing that if you need any support.
Yeah, I mean, it is kind of sad. I'm sorry to interrupt again, Belinda, but I do hope that in the next maybe 5 to 10 years, we will see open access take off. Not just because it limits people like yourselves from services, but it's also holding back people in less developed countries as well, who don't have access to all this expensive but extremely well done research. So it's something that the whole world is affected by, and it really needs to change in science.
Yeah. Yeah, and you know what I love is that, you know, I've had the privilege of developing a great, I think a mutually exclusive relationship with Matilda Centre, and it's been really, I think, cathartic for all of us, because we don't get to have these types of conversations about what's so helpful. And like everything, you know, you can say to young people, you know, when they're worried that everyone's looking at you, it's like, well, you're looking because they're looking. So we kind of get the same thing, right? And so the supporting a mentor. So when we got the CMHDARN grant, this was very exciting because, you know, we're all time poor, but it did give us some level of a small funding grant, but it was enough to actually help us actually start to get this momentum going. So the first thing we did was do a bit of a literature review around looking at what modalities were being used around working with young people with AOD and comorbid mental health, and looking at how you work with parents and what's being done around that. So I, you know, got to, unfortunately, I had done some research subjects, but I actually did three degrees to avoid stats. I mean, Steph knows, and I'm qual all the way, but she's also really encouraged me, as has the mentor that she provided for us. As Stephanie found Dr. Erin Kelly, who's also at the Matilda Centre, and she has been just amazing. I can't even tell you how much she normalises and validates and guides us. And a lot of the time, and you'll find the same, you're actually quite often on the right track. You're actually doing a lot of things really well. We just need those people to kind of go, okay, do this or do that. And it's just such a great thing. And that's what we got from CMHDARN. CMHDARN also, though, put some really good workshops on that I attended. And that was, again, and we all know, and we know this, it's not always about systems and services, it's about people. And work every room, always work a room. You don't have to chat as much as me, but work the room anyway, because when I can pick up the phone now and I know Steph, I can tell you it makes all the difference. So that's a really good thing. I also like to point about contacting authors. We definitely have done that. what was really funny is sometimes they're so busy, they're like, oh God, use what you want. And that was it. And other times they were very, very interested, and we developed some good relationships. So we did our peer
I
review.
will say that academics love their research. I mean, you'd have to stay an academic, I'll be honest. So
Absolutely.
if anyone is coming to you and asking for papers, they're going to be so happy.
They are. And I think what we're doing, Steph, is, I guess, reducing those barriers and misconceptions around our sector. I mean, look, you'll always get someone cranky in every service. I've got clinicians like that. You get that in everything. Just find your tribe. They're there. There's plenty of them, and they're there to help. So what we did after the peer review was we used some of the funding, and I reached out to some of our colleagues at NDARC and got somebody from there to help us do some data mining, some data diving, and we were starting to do that. And one of the things that's really important as an agency is if you don't have a policy around sharing, releasing information and stats and research, we made sure that that was all in our documentation. So for example, obviously when we're doing intake, in the intake process, we are already getting written permission for those things straight from the get-go, so that you've actually got that opportunity if you want to kind of go mining later. And that's something that we definitely did always. And we learned that through our CMHDARN kind of workshops and the importance of that. Then what we did was we had somebody, a lady called Nicole Clements, who was really lovely, and she came and did some work with us. And what we decided to do was we knew anecdotally that what we were doing was really helpful. We wanted to establish and develop our model to be a model in its own right, and to have the, be unique or die. This is what we were doing. But we wanted to be evidence-based. We found the literature that supported our hypotheses and our work. But then Nicole came and she did a couple of semi-structured interviews with previous participants from our service, and then did that thematic analysis. So looking for the primary kind of areas that really kind of, I guess, thickened up the hypotheses and where we were working towards, as opposed to what is the gold standard, what is best practice. And what we kind of found from our experience and through the literature and through client testimonies was that really the way we were working in separating parents and young people when we're doing that work was also recommended that when you have high levels of crisis in these families, you don't put them in a room together. People still do, but it's not actually best practice. So we just really stayed in that lane of finding out those things. But where it came from originally, and this is another little tip, you kind of might have a team that's got all different ideas. For us, it was very important in the survival of the NGO network, and we can all, I say this with a grain of salt, but a lot of the large welfare agencies, and they do very good work, but so do small NGOs, and we can get sucked up and disappear. And it is really important, if we're doing great work, that we can actually maintain and develop ourselves. For SDAG, we are very unique in what we do. I don't want us to be sucked up under somebody else's umbrella and become one of their programs. So therefore we just grew. And so when we'd done the lit review, and then we'd done the thematic analysis, then we did some outcome measures, how everyone's talking about, and that makes us all go. And as clinicians, I mean, we're very hard to convince to do another something in the room, right? But what we did is we just used what we had. So we used the OARS outcome rating scale, which is a self-reporting tool that we use, and we also use the DAS-21, and we use the severity of dependence scale. So we used a lot of the outcomes we already had to see if we could actually develop any snapshots over a period of time from what we were doing, and we got some preliminary data from that. So then we got to put that all into a paper. And the great thing was, and CMHDARN was beside us the whole way, then we actually put it into one of the conferences that was actually offering peer review for paper. So we were like, oh, hello. So because we'd had our fantastic mentors in our heads, it was like, oh, opportunity. And it's like, opportunity, it's all we need is opportunity. So we put that in and we got the paper peer reviewed. And even though it wasn't published, it was only published in proceedings, I don't care. I was excited as all hell. And it just meant that our agency had a peer-reviewed paper, and Steph knows that that's still a very meaningful thing to have when you're trying to look at the credibility of your work. And so what we did from then was we attached that to all of our tenders. And we actually started to then lobby for more money. And I'm pleased to say, even though sustainable funding is a constant bugbear and I'm always annoyed about it, it's not sustainable at this point, but it's certainly opened up doors for about 2 other large tenders, which enabled us to open a second service in St Leonard's and actually have a clinical team over there. So I can't even begin to imagine how we would have got here without that. Where we've kind of come from now is that the partnerships were probably some of the most main areas that were important for us. And just looking at the time, and this is where, you know, we've developed this ongoing relationship with other places. And so that's very much about your networking. I mean, our work, we're always networking anyway. So one of the things that I would always do was just wherever I was, would just try and pitch something and look at how we could contribute. I don't necessarily see all of our research on any kind of level of the hierarchy of knowledge that Steph was talking about, with all those ones where there's so many numbers. I'm kind of like, whoa. I don't think you have to have that. And there's people that do that. I've got someone in my team that loves that, and she can have it. And that's great, because it's about being collective and honing the strengths of your team to see who may be capable to have some of that work divvied out to them. And that was, once you get buy-in, and buy-in is the biggest thing when you're running a clinical team, everyone's busy. We know that. When you start saying to people, well, it's kind of really important that we stay in the front and the forefront of the fight, because it's also about our jobs. We don't worry our team about funding because we want them to do their work. But it's okay for people to remember that we can actually be in positions of losing it to other people if we don't keep up. And one of the things is a lot of people kind of balked at the way they were changing tenders and things like that. I totally hear you, but complaining doesn't actually get you funding. It was like move with the times and chip your way from the inside out. And that's one of the things that we've done. Now, what we've done now is, because we've got that, it's developed a very good profile for our agency. And this is one of the big importance. And then, you know, like Steph said, probably the hardest part was the accessing data. And in fact, I've been at many conferences where people have said, you know, we're doing this and we're starting this research and we want you to do this. And I'm like, we can't get database. I'm not doing another degree. How do we get database? So that was a bit of an issue. So I'm with Steph on this. This is something that we kind of need to look at and continuously lobby for, and we will. But it doesn't mean you can't do anything. If you've got somebody in your service who's already actually doing a uni degree, they've got database. You might do the list and find the preliminary stuff. I mean, sometimes it's good to get a research student from university, or get somebody who's got some access to database if you want to do a lit review, and you could probably take that on board and they might do that for you. Matilda have been so generous with us that when we were looking for a research assistant for our second CMHDARN grant, we found someone amazing, and in fact she was so good, she's going on to do clinical psychology, and we've just hired her for about 6 months until she runs away and disappears because she's got study to do. I've kind of tried to say to her, don't stay with us, but you know, she's got that to do. But these are about the networking and the building of partnerships and how that's come to growth and fruition, and you've got to nurture these relationships. We know that. It doesn't take much to do that though. So we have monthly mentoring with ours. We now got a second CMHDARN grant, which we were beyond excited about. The other one was in 2014, I think Joe might remember, but this one was just so exciting. So this is building on what we've already done. So now we're tapping into the unutilised resource, the importance of parents in treatment. And so we've now trialled, so there was nothing that we could nearly find. So when Steph said, go 5 years, we had to go 20 because we couldn't find enough about the subject that we were looking for, which was about what is the most appropriate tool that we could use to manage or measure well-being or changes in the family or all those things. So we had a lot of mentoring around that, and Joe was also from CMHDARN involved in that to help us find and select a tool that we could trial, was easy for our clinicians to do, to get buy-in and to actually start looking at contributing to the discourses. One of the things I think is really important.
Sorry, Belinda. Yeah, I just wanted to say that 5 to 10 year limit really shouldn't be a barrier. If you need to go back further, then do. It's all about finding quality research, but it just means that with some of those older publications, they might still need to be updated, or even, you know, think about the things that maybe they missed, because, you know, 20 years ago was a long time. Populations change, people change, ideas change, but don't let that stop you.
Yeah, great reiteration there, Steph. I completely agree with you. And no, it's not a barrier, but I also agree with Steph that, you know, when we were doing even some literature review, not around this one, but some other stuff just to recheck in what's changed since 2014, it was also about looking at those, I learned this through my mentoring, looking at the other, the authors from previous papers and stuff like that, and going back in and having a look. I actually, and I don't know whether this is a good thing, Steph, but I actually also
use controversial statement.
Academia.edu, like the academia website.
Oh, yeah.
What I do is, firstly, I got to put our paper up, which was great, but it was also about, I just am finding lots of stuff quite easily, because you can put in the topics that you love, and then it's constantly sending you kind of the ones that are relevant to you. So that's kind of a good one, right, Steph? Just for...
Yeah, and you can set up those kinds of alerts in the other databases that I mentioned today, so that you can get weekly alerts. I'm just conscious that it's 10 to 4.
Yes, so I'm pretty much done. So all I was going to say is we're just building, our second round is building onto the last grant and going from there. But that's kind of pretty much all I wanted to share with you all today. And I guess we'll go to Jo for any questions that people may have, or...
Hi again, everyone. We have a couple of questions. Linda asks, what about the copyright with an article which has been published in a journal and then contacting the author to provide a PDF when you don't have access to the journal? Steph?
It's not an issue because the journal will hold copyright of that article, but it's not like you're trying to republish that article somewhere else. All you're doing is asking for that article for your own personal use, and that's totally within the copyright. So yeah, you can always contact the author and ask them to send you a copy.
Okay, perfect. And then there was one other point, sorry, I'm just going to switch screens there, which is, it's probably good to mention the ADF library. So do either Belinda or Steph, do you want to talk about what the ADF library is?
I mean, I guess from the, I mean, Steph can talk about what it is. I guess from a service, I'm very, very familiar after 25 years in the sector of knowing what ADF is. Yeah, of course. I mean, they're just one of many places that we look at, and ADF has some really fantastic resources and opportunities there, as do some of the other ones that Steph mentioned. But yes, of course.
Yes, so in a 20-minute presentation, it's very hard to list everything. So I did try to do my best to be as kind to everyone as possible, but the ADF library is amazing. And it's definitely one of those websites that I was thinking about when I said, when you're looking to see what is about this website and the organization, you will definitely see that they write evidence-based articles, and you will be able to find and track down exactly where they've got their information from. So great resource, and I really encourage you to use it.
Okay, well, thank you both. It doesn't look like we have any more questions, so I think we'll wrap up there just in the name of time. But I wanted to thank you both, Belinda and Steph, for an incredibly illuminating discussion. Your expertise is much appreciated and acknowledged. For those attending, if you do have any questions that come up just as we're closing, or come up after you're thinking through some things, please don't hesitate to get in touch. My email is on the screen. I'm not going to spell it out. It's way too long. And look, thank you everyone for your participation today. We hope to see you at the next CMHDARN Research Skills Webinar, which will be on the 24th of March at 2 p.m. Registrations will open soon. And that webinar will be covering research methodology. So what's qualitative, what's quantitative research, and how to select the best one for your research project. So registrations, as I said, will open soon. Watch your email. But everybody, just thank you for attending today. And if there's anything else, just email. Thanks so much. Bye.
Thank you, everyone.
Thank you, everyone.